Just beneath the skin of the wrist, a rhythmic pulse provides a direct indicator of distal arterial blood flow. This diagram illustrates the arm's vascular anatomy. At the cubital fossa, the brachial artery bifurcates. The smaller terminal branch is the radial artery. Its primary function is to deliver oxygenated blood down the lateral, radial side of the forearm and directly into the hand. Ultimately, the vessel terminates deep within the hand itself, completing its circuit by forming the deep palmar arch. The clinical utility of the radial artery relies entirely on a specific structural transition. It begins as a heavily protected deep vessel, but eventually emerges into a highly accessible superficial plane, creating an optimal site for medical intervention. This flowchart outlines the standard approach to mapping the vessel. We will trace its origin, follow its course down the arm, identify its branches, and review its applied anatomy. Understanding these exact spatial coordinates is a strict prerequisite for safe surgical and diagnostic procedures. To trace this pathway, we start at the elbow. The radial artery originates precisely at the level of the neck of the radius. As it branches off, the artery positions itself strictly medial to the bone and runs laterally to the median nerve. At this proximal stage, the artery is heavily shielded by surrounding tissue, primarily the brachioradialis muscle. Looking at a cross-section of the proximal forearm, the artery sits deep beneath the large muscle belly of the brachioradialis. This reference text confirms the starting parameters. The beginning of the artery is securely located at the neck of the radius. Because the vessel originates deep within the cubital fossa, sandwiched beneath thick muscle and alongside nerves, this proximal zone is entirely unsuited for routine clinical access. Leaving the cubital fossa, the artery runs directly downward along the lateral side of the forearm. In the mid-forearm, the vessel's pathway is defined by a tight muscular boundary consisting of two specific structures. The lateral boundary is formed by the brachioradialis, and the medial boundary by the flexor carpi radialis. The artery sits completely sandwiched between them. The clinical flowchart tracks this exact descent, noting that the artery runs downward up to the wrist. As the artery approaches the distal end of the radius, the surrounding anatomy shifts. The large muscular bellies of both the brachioradialis and the flexor carpi radialis taper down into thin tendons. Without that thick muscular coverage, the radial artery is left protected by only a thin layer of fascia and skin. This precise spatial transition, from deep muscular entrapment to a superficial fascial plane near the wrist, creates the optimal, safe window for medical access. Upon reaching the wrist, the artery drastically changes direction. It winds dorsally, moving from the anterior forearm to the back of the hand. During this dorsal turn, it passes directly through the anatomical snuff box, running along its floor. To supply the palm, the vessel must navigate back to the anterior aspect of the hand. It achieves this by diving straight between the two heads of the first dorsal interosseous muscle. Inside the palm, the radial artery reaches its final configuration by forming the deep palmar arch. Returning to the flowchart, we can identify the vascular branches emitted along this route to support the surrounding tissues. In the forearm compartment, it gives rise to the radial recurrent, muscular, and palmar carpal, and superficial palmar branches. The document then lists a separate set of terminal branches that originate distally, inside the hand itself. These include the dorsal carpal branch, the princeps pollicis artery, and the radialis indicis artery. The radial artery operates as a highly branched distribution network that systematically shifts from the anterior forearm across the dorsal wrist and into the palm. This applied anatomy reference outlines routine procedures like pulse examination and arterial blood gas sampling. Both rely entirely on the artery's superficial position at the distal forearm. The solid bony backing of the distal radius provides a firm surface, allowing clinicians to easily compress the superficial vessel to feel a pulse or stabilize it for a needle stick. This accessibility also allows for more invasive applications, such as harvesting the vessel for coronary artery bypass grafting. But this presents a physiological problem. If the radial artery is the primary blood supply to the lateral hand, how can surgeons safely puncture or completely remove it without causing ischemia? The solution relies on the deep palmar arch we mapped earlier. The arch creates a collateral circulation system. It physically connects the radial blood supply with the ulnar blood supply, allowing blood to flow retrogradely from the ulnar side to the radial side. This structural redundancy ensures the hand remains fully perfused even if the radial artery is occluded or surgically harvested. The clinical text notes the specific protocol required to verify this system, Allen's test before cannulation. The logic of the test is straightforward. A clinician occludes both arteries, releases pressure on the ulnar side, and watches for color to return to the hand, proving the arch is intact. Failing to verify this collateral flow before an intervention can lead to devastating ischemia and tissue damage in the hand. The radial artery ultimately demonstrates how precise structural anatomy dictates clinical access and how physiological redundancy ensures that access remains safe.